question today is, are we there yet? And I'm going to talk about patient blood management and the Ontario program in this. Thank you. Now, I suggest to you that blood occupies a somewhat privileged position in modern medicine, in that it's evolved as a treatment option without the same level of research scrutiny, at least on the patient outcome side, that other treatments have been subjected to. So I'm going to discuss today why a change is needed in blood transfusion, why patient blood management, or PBM, and the Ontario program in this. Now, I have no conflicts of interest, but when it comes to transfusion medicine, I am indeed often conflicted. And the reason for that is that in 2013, a national summit in the United States identified 5 overused treatments that can harm patient safety and quality. And one of these 5 was blood transfusions. And blood transfusions are said to occur in 1 in 10 hospital stays with a procedure, and one of the top 5 fastest growing procedures in hospitalized patients. So we often hear that blood transfusions are safer than they've ever been. And I think that this statement is not only fundamentally untrue, but indeed misleading. It is safer from the risk of transfusion-transmitted infections, but there's still many other adverse events that happen with blood transfusions. We're all familiar with allergic, hemolytic, transfusion-related acute lung injury, and transfusion-associated cardiac overload, but there's still errors that occur with transfusion, and over the last 25 years or so, we've become more interested in transfusion-related immunosuppression or immunomodulation, sometimes called TRIM. Now, if indeed, as has been shown, transfusions are associated with immunosuppression, you would expect that people who are transfused are more susceptible to getting infections. And indeed, the literature is abundant. There are many, many articles showing that transfusion is indeed associated with an increased risk of infections, and it's been said that red cell transfusion is the strongest independent predictor of all-cause morbidity and mortality, and that each unit transfused poses an additive risk. And we've found, the literature shows, that transfusion is correlated with increased time to extubation, increased ICU and hospital length of stay, morbidity, and mortality. So what can we conclude about the benefits of blood transfusion? Well, in fact, the evidence of benefit from blood transfusion is actually quite difficult to find. There's never ever been a prospective randomized study to establish the life-saving benefits of red cell transfusion, and we assume its benefit even though it isn't proven. It is clear, it's obvious that some patients will benefit from transfusion, but we need to be able to better identify which patients they are. We have learned that giving more blood is not necessarily better, and many transfusions are probably unnecessary. So when should we transfuse? Well, we know that 30 to 70% of patients, depending on their diagnosis, but 30 to 70% of patients come to surgery anemic. There's a long tradition of accepting anemia as a relatively harmless problem that can be easily corrected with a transfusion, and for many this remains the default position. But anemia is in and of itself an independent risk of morbidity and mortality, and increases the costs of delivering health care quite considerably. We know that in the ICU, patients are mostly anemic at the time of admission, and that the hemoglobin declines at least 0.5 grams per deciliter a day in the first 3 days of an ICU stay, and continues to decline if the patient is sick, they have sepsis or severe illness. And these are patients that are particularly at risk from anemia because they have cardiovascular, respiratory, and metabolic compromise. Now, the anemia in the ICU is multifactorial, but I need to point out the very large contribution to that anemia of diagnostic blood taking. It's been shown that one is amazed at the amount of blood lost in taking blood for diagnostic tests, often equivalent to that which is transfused. Now, establishing a definite hemoglobin transfusion threshold or trigger, when should you transfuse, has proven difficult, but studies have shown that mortality increases in patients when the hemoglobin falls below 5. For healthy individuals, it may be even lower, but comorbid conditions such as trauma, sepsis, cardiovascular disease can influence this threshold. And currently, many hospitals are steering toward a hemoglobin trigger for transfusion of 7 grams per deciliter, regardless of comorbidities. Some use 7 for so-called healthy patients and 8 for patients with cardiorespiratory problems. But the main point is to avoid transfusing healthy patients based on a number, a hemoglobin alone. You need to evaluate the patient. And why do we need to change transfusion practice? Because these two graphs show you that transfusion is associated with increased mortality, and that even 1 unit of transfusion increases the likelihood of mortality. The literature tells us or suggests that up to 60% of transfusions given are in fact unnecessary or inappropriate, that they're given to stable, non-bleeding patients. An amazing observation has been the variability in transfusion rates. And this study, looking at over 80,000 patients in over 400 hospitals, showed that the transfusion rate for CABG, cardiac surgery, ranged in one hospital from 8%, another hospital to 99%. So in the presence of clinical uncertainty, the default position has been to administer a blood transfusion, and this isn't usually the case with other therapies. Patient comes in with fever, you don't automatically put them on antibiotics. They come in feeling weak, fatigued, you don't automatically put them on chemotherapy. But we do give the patient with anemia transfusion. And I suggest to you that transfusion is inherently hazardous and costly and should only be prescribed when there's evidence that the benefit would outweigh the potential for harm. In addition, transfusion is costly. There are direct and indirect costs of producing the product, and an evaluation in Canada suggested that the cost of producing a unit is 450 Canadian dollars a unit. But in addition, there are other costs in the hospitals where you have to do cross-matching, where the nurses administer the blood, monitor the patient, and so on. In addition, there's further increase in resources when the patient has a longer length of stay, when they develop infections and other complications of transfusion. And several studies have suggested that, in fact, the cost of a transfusion of a unit of blood is around $1,400 a unit, which I think translates to around 80,000 rupees. Another issue for transfusion has been supply and demand. As our population grows more elderly, you can see in the bottom table that if you're under 40 years of age, the average use is 5 units of blood per 1,000 population. If you're over 70, you use 200 units of blood per 1,000 population. So there have been concerns about whether we can meet the demand. So this brings us to what's called the precautionary principle for transfusions, and that is transfuse only when absolutely necessary, tolerate anemia. When you do need to transfuse, give as little as possible, 1 unit at a time, reassess the patient, see if they need more on a clinical basis. And this has led to a focus on patient blood management, or PBM, which is aimed at using blood transfusion in the most optimal way. Patient blood management has also been called blood conservation or bloodless medicine or bloodless surgery. But there are many definitions, but I like this one because it's relatively simple. PBM is the timely, multidisciplinary application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in an effort to improve patient outcome. And I suggest to you that PBM is one of the few areas in medicine where you can improve outcomes, reduce risks, and save costs all at the same time. Now, I think that you still have a problem in blood donations in India. And the top graph looks at the whole blood donations per thousand population in data from the World Health Organization, and you can see that India still remains at a low level of whole blood donations. The bottom picture shows you an improvement, however, in that there has been a very significant increase, an 85% increase in India in voluntary, non-remunerated blood donation. And that, of course, is an important component of any successful blood program. So you're to be congratulated in the increase in voluntary donors, but I think that you still need to improve your overall blood donor population. Now, with regard to patient blood management, there has been some suggestion of that in India, and I found this headline from a newspaper, an Indian newspaper, saying blood management solutions have come to India. Unfortunately, this headline related completely to an advertisement for a particular machine, the ROTEM, or thromboelastography. But the article did say that PBM is an international initiative in the best practices of transfusion, an important concept to prevent unnecessary blood transfusions, and goes on to say that India is yet to introduce a protocol for this, though the concept is in use in a limited way in some specialty hospitals. That was in 2016. So what can you do to reduce the risk of transfusion? Well, there are many things, both preoperative, operative, and postoperative. Important is to correct the preoperative anemia, reduce blood loss, use a lower transfusion trigger, tolerate anemia in a patient, minimize the amount of blood given, optimize coagulation prior to surgery, and so on. So there are many things that can be done. So what did we do in Ontario? Well, we formed the OnTrack program, which is the Ontario Transfusion Nurse Coordinators Program, and this is a network of PBM nurse coordinators in 25 hospitals aiming to implement patient blood management in their institutions. It's funded by the Ministry of Health, and its focus has been the elective surgical setting. So in 2002, I went to the Ministry of Health, and after many meetings and a 70-page proposal, eventually they agreed to fund this network. And the aims of the transfusion nurses, the PBM nurses, is to enhance transfusion practice outside of the blood bank, to act as a clinical bridge between the transfusion service and the rest of the hospital. And these 25 hospitals account for 70% of the province's blood, around 400,000 units a year. So the nurses are to interact with physicians, nurses, and patients to promote blood conservation and avoid allogeneic transfusion. Initially, we targeted total knee arthroplasty, abdominal aortic aneurysm surgery, CABG, and radical prostatectomy, but we've now included hips, gynecologic surgery, valve surgery, and so on, with more procedures. So basically, what do the nurses do? They assess the patient when the patient comes in to the pre-admission clinic 3 to 5 weeks prior to surgery. They identify patients at risk of transfusion, discuss informed consent and alternatives to transfusion, identify, investigate, and treat anemia with the help of the family doctor, the surgeon, the anesthetist, or the hematologist, and they develop individualized treatment plans for the patients and facilitate treatments when appropriate with erythropoietin, iron, tranexamic acid, and so on. So how has this program been successful? Well, I think this graph shows you that indeed it has. That when you look at the left-hand side of the graph, the bars in blue, you can see that we've reduced the transfusion rate in the province in knee surgery from 25% to 2.6%. In CABG surgery, we reduced the transfusion rate from 60% to 24%. It seems to have stabilized in CABG surgery, and I'm disappointed in that, but we're looking into why that is. The table at the bottom shows you that not only are fewer patients being transfused, but those that are being transfused are getting less blood. I pointed out the interinstitutional variability in the literature. The top graph shows you the findings at baseline when we started in knee surgery. And you can see in the blue that if you are hospital number 1, this is for knee surgery that has the same kind of patient, the same procedure. The patient should be the same wherever they are. But in hospital number 1, there was a 68% transfusion rate. In hospital number 23, there was a 2% transfusion rate for basically the same procedure. But you can see that as of last year, we've had a marked reduction in all institutions and a flattening of the interinstitutional variability. And in fact, this year, 73% of the hospitals had no transfusions during knee surgery at all. So how do they do this? You need to standardize your approach, and the nurses themselves have developed this algorithm for managing anemia in pre-surgical patients, and we have a toolkit guide of 50 pages, and these are available. You can get them if you want on the OnTrack program website. Now, we try to get the patient's hemoglobin prior to surgery to 130 grams per liter or 13 grams per deciliter. And the reason for that you can see on this slide. And you can see that below the red line, red dotted line, that when the hemoglobin is, pre-surgical hemoglobin is above 130, the dramatic decrease in allogeneic transfusions that is present. So that a preoperative hemoglobin of 100 has a 7-fold higher likelihood of transfusion than a hemoglobin of 130. So we try to get our patients to 130 or as close to it as we can. But of course it takes time to correct the anemia, and this graph shows you that the longer the time the nurses know about the patient, the longer the time, the lower the transfusion rate. So it's important to see the patients as early as possible, and that sometimes is difficult. They're not referred to the nurses early enough. What the nurses love to do, because it's easy, as soon as they see a patient that's going for surgery, they put them on oral iron. And you can see in the top half of this picture that the increase in oral iron from the initial hemoglobin, the hemoglobin when they see the patient, to the pre-op hemoglobin, there is no increase, in fact. And the reason for this, and this is in contrast to IV iron that you see on the bottom, and the reason for this is because there isn't enough time for the oral iron to have its effect. If you have many weeks or months that you can treat the iron deficient patient with oral iron, that is an appropriate treatment. But if you don't have the time, it really is ineffective in the pre-surgical setting. Another thing that we push is the use of tranexamic acid or antifibrinolytics. Now, antifibrinolytics, tranexamic acid, is widely used in cardiac surgery. Over 90% of patients going for cardiac surgery will be put on tranexamic acid, which prevents or reduces bleeding. But it wasn't much used in orthopedics. So you can see on the left, the blue bars, that we have had an increase in orthopedic patients receiving tranexamic acid, so that over 80% of them now do. And on the right, you can see that when patients do receive tranexamic acid, there is a much lower transfusion rate. So I think this has been a successful implementation in our experience. While giving a patient one blood conservation measure is effective, the use of multiple blood conservation measures in the same patient is even better. And you can see here that the use of multimodal blood conservation reduces the transfusion rates. Now, we measure also outcomes, and the outcomes that we particularly measure are infections, length of stay, mortality, and cost savings. And you can see in these graphs, I think, that they show that patients who are transfused in the red bars have a longer length of stay in hospital and a higher infection rate post-operatively than patients who are not transfused. And this effect is in fact dose dependent. The more red cells they get, the higher the infection rate and the longer the length of stay. In terms of cost savings, because the Ministry of Health funds the program, they want to know about cost savings. So we evaluate that. And with the reduction in patients transfused and reduction in amount transfused given to transfused patients, we've annually saved the province around $13 million a year. The savings to the healthcare system overall, when you include reduction in length of stay and reduction in infection rates, is around $35 million, which I think it's a little difficult for me to convert that, but I think it's around 400 crores. But whatever, that's the number of Indian rupees. The cost of the program is $3.4 million. So in addition to catering to many patients' preferences, improving quality of care and patient safety, I think the program is cost efficient and cost effective. But there are difficulties in developing and running such a program. There's been an emphasis on shorter wait times for surgery, and sometimes this doesn't give us enough time to correct the anemia preoperatively. There's changing scientific evidence with regard to the efficacy and dangers of some of the measures that we use, and we need to constantly evaluate that. Some of these measures are costly, and we have to find ways to deal with that. When there's a turnover of the nurses or administrators or doctors, there's sometimes a reversal in gains, and it was initially quite difficult to recruit physician and administrative champions. But senior hospital leadership is important, and cardinal to success is a well-respected physician who will act as the local champion, helping the coordinator develop procedures and protocols and presenting them to staff. It's important to understand the institution's culture. In this program, we're involving 25 hospitals. Some are university hospitals, teaching hospitals, others are community hospitals, and we need to understand the differences between them rather than it isn't one size fits all. To change practice needs data on current transfusion rates and practices, and we get buy-in by sharing comparative data because no one likes to be worse. We have learned that we like to blame the anesthetist or the surgeon when patients get transfused, but in fact transfusion rates are not patient dependent but are institution dependent, and that there are some hospitals that are high transfusion hospitals and other hospitals are low transfusion hospitals. And while 30% of the variation may be surgeon or anesthetist specific, 70% is hospital specific. So what we need to do is change the culture in the hospitals. Now we know this, so why haven't we changed? Because we all say, yes, change is good, but you go first. So I like this editorial that tells us from 15 years ago that bloodless medicine, or PBM, is not easy. It requires coordination of services across departments, cooperation in outpatient scheduling, surgical anesthesia physicians, clinic personnel, operating room scheduling, intensivists, hematologists, billing office. And this is in contrast to a transfusion, which you can accomplish with one single phone call. There are many new techniques and therapies available for PBM, which are still being investigated, but it is becoming standard of practice. Now, is it in use in India? Well, the one thing I could find in the literature is there was this paper published a few months ago in the New England Journal of Medicine in February 2018 on the TRIX-3 trial, or transfusion requirements in cardiac surgery. And this was a large trial, 5,000 patients, 19 countries, and I show you that India was an active participant in it with 134 patients submitted, in contrast to the United States with 82 patients submitted. So clearly there is an interest in India, and at the bottom you see at least 3 references that I could find on patient blood management in India. So are we there yet? No, we're not. We're getting there, but there's still difficulties to encounter and deal with. But patient blood management is the predominant paradigm in clinical transfusion medicine today. And the success of PBM can be seen by the falling demand of red cells around the world. And many clinical trials have demonstrated how restrictive transfusion thresholds are associated with better clinical outcomes. So I want to leave you with this famous statement of Dr. Beale from Australia, that blood transfusion is a lot like marriage. It should not be entered into lightly, unadvisedly, or wantonly, or more often than is absolutely necessary. And for those blood bankers among you, there's this cartoon. It's tragic, really. He died because no one knew his blood type. But I'll never forget his last inspirational words he whispered to me: be positive. So I thank you, and hope I can